It's now my pleasure to introduce Professor Julian Trollor, who I actually think is probably known to most of you. Julian is the Chair, Intellectual Disability, Mental Health. He is the Head, Department of Developmental Disability, Neuropsychiatry, and Professor, School of Psychiatry here at UNSW. He is also a clinical academic within South East Sydney Local Health District. Julian provides a tertiary referral clinic for people with intellectual and developmental disorders and complex mental health needs, and in his university role he undertakes research, teaching and capacity building in intellectual disability health. His aspirations for the public mental health sector with regard to people with an intellectual disability is for mental health services and staff to be equipped to provide quality mental health services and supports for people with intellectual or developmental disabilities. Thank you, Julian. He's going to introduce the framework and the toolkit.
Thank you very much, Beth. Minister, it's a privilege to have you here today, and thank you for those inspiring words as we seek to take this document and apply it to our clinical practice. A document alone is in itself meaningless. So the key goal here, I think, is to introduce this tool to you in order that you can harness its contents to use to improve the mental health and wellbeing of people with intellectual disability. I'd also like to just acknowledge at the outset the tremendous support received through Beth Kotz and her staff Tanya Skippen and Bernadette Dagg in the preparation of this document, and the incredible input from the working group that included a number of people in the room, including David Dossiter, I think, and Rod McKay. I saw Rod earlier. I'm not sure if anyone else from the working group is here, but those are the ones I've spotted so far. Thank you also to David Pearce and South East Sydney Local Health District for supporting this launch on site here in the local health district in which I work. It's especially pleasing that we didn't have this elsewhere, because I feel very much part of this local health district, having, I think, worked here for nearly 30 years in one capacity or another. So it's wonderful to be here. I'd also like to acknowledge Yvonne Stocker's artwork. The front of this document features her artwork, and 3 of her works are here today. So it's a special privilege to have Studio A allow us to exhibit those artworks, and I think that helps us engage with the task at hand. Australia is a signatory to the UN Convention on the Rights of Persons with Disabilities. And in that convention we see a really clear articulation that people with disabilities have the right to the highest attainable standard of health and wellbeing. At this point in time, for people with an intellectual disability, there's a large gap between the highest attainable standard and the actual standard that they experience day to day. This gap is illustrated by Australian data. We know that in our national mental health and wellbeing surveys that about 2 in 10 people in our community experience a mental health problem in about a 12-month period. For people with intellectual disability, however, this number is vastly greater, as illustrated in this graphic. And furthermore, the mental health of carers of people with intellectual disability is significantly impacted by the caring role. So we have a challenge. How do we meet the gap between the expectations in documents like the UN Convention and the current reality? Well, I think the first thing is for us to understand the issues that are contributing to this gap. There are multiple risk factors for mental ill health in people with intellectual disability, both biological, some of which are involved in the nature of the disability itself. Some of our genes contribute to this vulnerability. Some of the psychological factors. If you're a person with intellectual disability, you may experience some difficulty in adapting to change, in adapting to anxiety-provoking situations, in taking stock in a way that allows you to use skills to mitigate the stress or distress of things that occur in life. As a person with intellectual disability, you may be much more likely to have experienced an abuse experience in the past, and this too contributes to risk. We know from research that lifestyle factors that link to mental ill health, drug and alcohol use is especially prevalent in people with borderline levels of disability or milder levels of intellectual disability who are not currently supported by disability services. We know that physical inactivity can be experienced more often by people with intellectual disability, poor diet, poor lifestyle. So these factors have a bearing. We know that environmental triggers are a real key. If you're a person with intellectual disability, you may not have a choice about where you live, who you live with, and you may have less of a choice about what you do in your day-to-day activities. So these things provide, I think, less choice and control than would otherwise be preferable and may contribute to risk. And there are a number of social risks and economic risks to mental ill health that are experienced by people with intellectual disability. It's not just, though, about the individual vulnerability. It's understanding the multiple barriers a person with intellectual disability and their carers experience when trying to access quality mental health care. A person with intellectual disability may have communication difficulties and may require adjustments to communication, as the Minister mentioned. But if that's not done, then a barrier exists. We know from the coalface that a lack of specialised services presents a barrier, and a lack of the equipping of mainstream mental health services presents a barrier in many areas. We've recently conducted a survey across Australia of all nursing and medical schools and looked at the amount of intellectual disability health content in curricula nationwide and found an incredible lack of equipping of future doctors and nurses in this area. And I think that feeds into a lack of professional awareness as we begin to work in our professional lives in mental health. We need to do a lot about that. We also know that often carers and those supporting a person with intellectual disability in the community lack awareness about how mental illness may manifest in a person. This is important because often it's a carer who is ringing alarm bells or trying to access a service on a person's behalf. If you don't know how mental illness may present and you don't know how to access services, then that presents us with another barrier. And fortunately, the Minister has also highlighted the lack of cohesiveness between services, which we're here to address. If we don't talk to one another in the different service compartments, if we don't have ways of interacting, if we don't streamline those, then we're not able to meet the needs, support needs of the person across a range of domains, and this presents a barrier. We know from our own data linkage study at a statewide level that there are major implications here then for services and for costs of services. So I'd like to encourage you not only to be motivated by the will to reduce some of those barriers and to address some of those individual vulnerability factors for people with intellectual disability, but to consider too the service benefits of doing a better job in this space. Currently we know that people with intellectual disability, when compared to people without, are twice as likely to be admitted to a mental health ward, more likely to be brought by emergency services, stay twice as long, cost the system twice as much, are often younger and socially disadvantaged, and are more likely to be diagnosed with disorders such as schizophrenia and less likely disorders such as depression. We also know that people with intellectual disability are more likely to be given a no diagnosis label. That is, we're unsure what's wrong. And I think this is a point of significant concern. If we're uncertain the nature of the problem, then we may not be able to help that person achieve the best possible mental health and well-being. I think often that label is given because of a lack of clinical skills or a lack of assessment skills in the area. And I'm really grateful for you being here today to try and look at how we do that sort of assessment much better than is currently done. We see the same picture in our ambulatory mental health services when we look at large data sets. So in that sector, we know that the number of visits is higher for a person with intellectual disability, consultations are longer and more complex. But not only that, when we talk to consumers and carers, they report a range of experiences. Not all of them are bad, but I feel most of them are actually remediable. We're able to do something about most of the issues that come up for carers and consumers. And I've just highlighted some of the quotes that are included in the competency framework here that help us understand this space. I'll allow you to read them. So concerns about not being listened to, concerns about lack of preparation in the consultation, lack of information sharing, lack of access of that information when it exists. But then there are some very positive comments about doing a great job in a crisis, supporting the person at home, meeting the person's needs in an individualised, person-centred manner, liaising with disability workers, feeling confident if the person is put first, if the person themselves is acknowledged as the centre of their care and engaged to the greatest extent possible. And the real difference it makes in outcome when the right assessment and treatment is possible. And this quote, I think, is really telling, that the right treatment has meant that she is back to normal in terms of her mental health. So this is a recovery-focused approach. She's on the ball, independent, confident, and has gained a work promotion. How satisfying that is when we do a good job. As you've heard, there are a range of things that need to be done. Today is one incremental step, a small step, in a long chain of things that needs to happen to improve the mental health and wellbeing of people with intellectual disability. We're fortunate in our department to be funded, as the Minister has said, for many years to come, to enable us to complete some more of this work framework that is talking about workforce development. So far we've ticked off a number of boxes, but there is a lot to be done. There's a lot to be done for people and with people with intellectual disability in terms of improving tools for a person to access information. A lot to be done with families and carers. A lot to be done both in the mental health workforce and the disability workforce, but we have a framework and a way of approaching this issue. Many of you will know that in 2014, in collaboration with the Australian Association of Developmental Disability Medicine and New South Wales and National Council for Intellectual Disability, we launched this national document, the Guide. If you haven't heard of this document, please visit our website and download it for free, or contact us if you wish to purchase a copy. There are some display copies available today. This really sets the groundwork for what accessible services look like for people with intellectual disability. If you haven't already accessed it, as a health worker, you're able to access free training, which is available in our learning portal. This will also shortly be available through the HETI online system, but you can access it anytime, anywhere for free with a log-on. It has a portal for mental health workers, and it's soon to have modules also available for the disability service sector. And then on today to the competency framework. It's apparent from the lengthy title and the title of our department that we love complex names. But I think what we need to do is think about this as a framework, a manual, that we can apply in a practical sense to our work. And I'm delighted that so many people have agreed to stay for the workshop to help us do just that. The manual is here to support your good work and to in fact allow you to access appropriate tools that improve your capacity to assess and manage people with intellectual disability in a lifelong learning approach. We acknowledge that it takes time and effort and persistence to develop skills in an area like this. But having worked in mental health for many years, I'm also very clear in my mind that working in this area is not a giant conceptual leap. Most of the skills as the mental health workforce, most of you have the skills and apply them every day in other areas of your work, in people with complex needs or cognitive disorders. And so for most of you, contextualising your practice to people with milder levels of intellectual disability will come relatively easy. And it will be helpful for you to be able to access the tools and information here to ensure you're doing a good job for those people and to help you extend your clinical practice to people with more complex needs. The manual is vividly illustrated and I hope sensibly organised. It has really come about because of a very comprehensive working group and extensive consultation. People have given their time freely to participate in this process. So any talk that it's a success of mine, I think, is really not quite right. This is a group effort. I'm fortunate to have the support of wonderful staff who have worked on this document, and the content essentially driven by a steering group is the summation of ideas of experts across the country. They're not my thoughts, they're the thoughts of the sector and of professionals who lead in this area. Obviously, in the process, we also conduct extensive literature review and consultation regarding what's being said. So, the intended use of this manual, well, it's for use for everybody who works within the mental health service system. It'll help you make reasonable adjustments to your practice. It'll help inform your professional development plans and be very useful as a resource, as a guide to your education and training in this area. It won't surprise you that we're not stopping there, that we're developing an equally as vivid toolkit to assist your implementation of this framework. And that toolkit will be launched on our website in the coming weeks. So that's enough from me. I've been given the wind-up from the front row here. So I'd like to acknowledge a number of issues and people here. I'd like to acknowledge the core funding that I receive, which is a generous core funding to enable us to conduct projects like this and to build capacity in this area. And this comes from two directions, from Ageing, Disability and Home Care, Family and Community Services, New South Wales. And I'd like to acknowledge David Coyne, the Executive Director of Clinical Innovation and Governance, until recently with ADAC, and now poached essentially by the National Disability Insurance Scheme, who has, together with his office, helped us shape the direction of the work plan of the Chair, and the Mental Health and Drug and Alcohol Office of New South Wales Ministry of Health, who support this work extensively, not just this work but other work through multiple projects and partnership in research. Obviously, as an academic department, we have multiple different funding sources and research projects, and I'm obliged to mention them. But particularly, I'd like to thank, as I think I already have, Beth Kotz, Tanya Skippen, Bernadette Dagg, who from the Mental Health Children and Younger Persons Unit have provided us with the expertise and the partnership to enable us to develop this framework. I'd also like to acknowledge Janelle Weiss, who I didn't acknowledge earlier, who is in the room and part of the reference group, and the incredible work of Claire Eagleson and Jessica Walsh. I think you've all had communication with them, two staff members of my department who've worked tirelessly, and I mean tirelessly, often without much sleep, I think, particularly in the last few weeks as we've prepared for today. And Studio A, previously known as Studio Arts, who's provided all of the artwork throughout this framework. Thank you for coming. Thank you for your passion and interest in this area. We hope that together, if we work to build skills, that will make a real difference for people with an intellectual disability and know better how to work with people with intellectual and developmental disabilities. Thank you.